everyone. My name is Candy. I'm the Operations Administrator for Living Well, and we would like to thank you for coming to the Understanding Colorectal Cancer informational talk with question and answer. And not sure you're all aware that Governor Pritzker actually made March colon cancer month in the state of Illinois. So this is very timely information. And again, Dr. Hardy, thank you so much for presenting for us tonight. We really do appreciate you. And let's take it away.
Okay, thank you very much. So just to briefly introduce myself, my name is Dr. Ashley Hardy. I am one of the surgical oncologists with the regional medicine medical group at Northwestern Medicine. I mostly practice out of Central DuPage Hospital and Delnor Hospital. We see patients in the outpatient clinic at the Warrenville site and the Delnor site. I am originally from North Carolina. It's where I did my medical and undergrad training. I did my general surgery residency downtown at Northwestern before doing a complex general surgical oncology fellowship at Fox Chase Cancer Center in Philadelphia. For the first 6 years of my post graduate career, I spent it in a little town called Goshen, Indiana. It's not too far from South Bend, before coming back to my second home at Northwestern 2.5 years ago. So happy to be back, and happy to have this discussion with you guys. It's a very general overview, and hopefully you learn something from it. But of course, afterwards, I am more than happy to take any questions and hopefully be able to answer those for you. So you can go to the next slide. Okay, so in terms of the objectives of my talk, I want to first review some general facts about colorectal cancer, then discuss how it develops and its associated risk factors. We'll then move on to common symptoms patients may experience, review the current screening guidelines and types of screening modalities available, discuss how we work up and stage colorectal cancer, discuss the treatment options available, for which, since I am a surgical oncologist, will be a little bit heavier on the surgical side. Next, we'll touch on metastatic disease and how we approach those cases, followed by a quick rundown on how patients are monitored after completing treatment. And then finally, just a very quick review on ways to reduce our risk of developing colorectal cancer. Next slide. So colorectal cancer is currently the third most frequently diagnosed cancer in the U.S., with an estimated 154,000 cases diagnosed last year. It's also the second leading cause of cancer deaths in this country, accounting for almost 53,000 deaths last year. But despite these jarring numbers, there's been an overall decline in the incidence or number of new cases and mortality from colorectal cancer, owing, largely to earlier detection and removal of precancerous polyps as a result of screening efforts. This holds true with most age groups, with the exception, however, of those adults under the age of 50, for which we're actually seeing an increase in incidence. Next slide. So this is demonstrated in these graphs, which show with the bottom two, the bottom four rather, that while the incidence and death rate from colorectal cancer has steadily declined over time for those age 50 and older, that we're actually seeing an increase in both the number of new cases and mortality rates for those between the ages of 20 and 49, represented with those top two graphs. In fact, colorectal cancer is currently the leading cause of cancer death for men and second leading cause for women in this age group. And the underlying reason for this trend is unknown, as most young patients develop cancer in the absence of the typical risk factors. What we do know, however, is that they tend to be more aggressive biologically, and that young people tend to be diagnosed at more advanced stages, owing likely to their aggressive nature and because of delayed presentation. Next slide. As with many health conditions, racial and ethnic disparities exist, with Native and African Americans having a higher incidence and mortality rate from colorectal cancer compared to other populations. In fact, when it comes to African Americans, 20% are more likely to be diagnosed and 40% more likely to die from colorectal cancer compared to most other racial and ethnic groups. The reality of these trends that we're seeing with race and age was, demonstrated with the unexpected death of Chadwick Boseman, also known as the Black Panther, who unfortunately passed away from colorectal cancer at the age of 43. In terms of these disparities, this is thought to be multifactorial. Next slide. With a lack of access to quality cancer programs, certain biases and beliefs held by providers, and lower income, lack of insurance or being underinsured, and lower rates of educational attainment all playing a role. Next slide. In addition to age and race, other known risk factors for colorectal cancer include genetic susceptibility and inflammatory bowel disease. So this includes ulcerative colitis and Crohn's disease, as well as what we consider to be modifiable risk factors like diet, obesity, physical inactivity, smoking, alcohol consumption, and type 2 diabetes. Compared to patients of normal weight, obese men have a 50% higher risk of colon and 20% higher risk of rectal cancer, whereas obese women have a 20% higher risk of colon and 10% higher risk of rectal cancer compared to their normal weight counterparts. And with regards to alcohol, a recent report from the U.S. Surgeon General highlighted the link between cancer and alcohol consumption, with colorectal cancer making the list alongside liver, esophageal, breast, and head and neck cancers. The likely reason for this link is likely due to the damage that alcohol can cause to cellular DNA and its repair mechanisms, much like what we see with diets high in processed and red meats. Next slide. In terms of genetics, up to 20% of patients with colorectal cancer have a family history of the disease, for which 5% are due to an inherited syndrome. In fact, people with a first-degree relative have a 2 to 4 times greater risk of developing the disease compared to those without. And the same holds true for those with relatives diagnosed before the age of 50 or who have family members with a history of multiple adenomas or polyps. The most common hereditary syndromes are Lynch syndrome or hereditary non-polyposis colorectal cancer, or your polyposis syndromes like FAP and MAP syndrome. The important thing to know with regards to Lynch is that these individuals are also at an increased risk for other cancers, including endometrial, ovarian, pancreatic, biliary tract, and urinary tract cancers. And individuals with FAP or familial adenomatous polyposis have essentially a 100% chance of developing colorectal cancer by the time they reach the age of 40, due to the presence of hundreds of polyps that carpet the lining of the colon and rectum. This risk is so high that, patients with this condition are advised to undergo prophylactic removal of their entire colon and rectum, usually by the time they're, 20 to 25. Next slide. So this is a very busy slide, but just highlights the criteria that we look for to determine if a patient does in fact have Lynch syndrome. And while again, this only constitutes about 5% of colorectal cancers, if present, as previously mentioned, it can have implications in terms of screening and treatment recommendations. Next slide. In terms of symptoms, patients may complain of blood in their stool that's either bright red or dark and tarry, abdominal pain and bloating, rectal pain, loss of appetite, weight loss that's unintentional, Blockage like symptoms such as nausea, vomiting, constipation, may have what seems like chronic diarrhea, stools that are thinner than usual, or have newly diagnosed iron deficiency anemia, which, as they teach you in medical school, is colorectal cancer until proven otherwise. And this is why, I stress to patients that if they develop any of these symptoms, that it's important to talk to their doctor and not just assume that the occasional bleeding they're seeing, with wiping is due to an hemorrhoid, because it may actually be an early clue to a more serious diagnosis. Next slide. In terms of colorectal cancer development, the natural history is that these cancers arise from polyps that develop from the inner layer of the intestine that, if left in place, can over time develop into a cancer. And as that cancer progresses, it grows through the deeper layers of the intestinal wall, eventually gaining access to the lymph channels and blood vessels, which may allow it to spread to other sites. On average, this process can take several years. That's why, for average risk individuals, they tell you to get, screened every 7 to 10 years. But, obviously there are cases in which, these cancers can develop more quickly. But this is why it's so important to undergo regular screening, because you want to remove these polyps before they're able to develop into a cancer. Next slide. Currently, all of the major medical societies recommend starting screening at age 45 for what we consider average risk individuals. For a long time, as many of you remember, the recommended age was 50, but this was lowered to 45 about 5 years ago or so in response to the disturbing trend that we're seeing in younger patients. And based on what we're seeing now, I honestly wouldn't be surprised if that age was lowered even more in the near future. You're considered average risk if you have no personal history of colorectal cancer or precancerous polyps, or inflammatory bowel disease. If you don't have any family history of colorectal cancer or one of the genetic syndromes. And it's recommended that you, continue screening up to age 75 if you're in good health and have a life expectancy that, exceeds 10 years. And beyond that, it's based on personal preference and prior history, although I tell my patients that if they're healthy enough to make it onto the table, that they should get a colonoscopy. Next slide. You should undergo screening earlier if you have a genetic predisposition to colorectal cancer, as seen here. For those with a first-degree relative with a history of colorectal cancer, your screening should start at the age of 40 or 10 years before the earliest diagnosis. For those with IBD, screening should start approximately 8 years after symptom onset. And for those with a colorectal cancer syndrome, screening begins at a much younger age, again, because the risk of developing cancer is so much higher. Next slide. This is for colonoscopy specifically, but you see the impact that screening has had in that as the rate of screening has increased over the years, the incidence of colorectal cancer has declined. Next slide. This has led to a huge push nationally to improve screening efforts, notably with the 80% in every community campaign. Established by the National Colorectal Cancer Roundtable. The inspiration behind this campaign is the fact that over 60% of colorectal diagnoses are attributed to non-screening, and that if we're able to increase screening rates to at least 80%, we could prevent an estimated 280,000 new colorectal diagnoses by the year 2030. Nationally and for the state of Illinois, the screening rate is about 60%, which isn't bad, but obviously there's room for improvement. Next slide. While the goal is to find and remove polyps, before they turn into a cancer, with regular screening, cancers can be found at earlier stages, which in turn, leads to a greater chance of survival. The majority of colorectal cancers are diagnosed at either, the majority of colorectal cancers that are diagnosed are either localized, meaning they're confined to where they started, and this typically corresponds to stage 1 or 2, or they have evidence of regional spread, meaning they've spread to the lymph nodes surrounding that part of the colon and rectum, corresponding to stage 3. But in either case, the 5-year survival exceeds 70% with treatment. But when it comes to metastatic disease or cancer that's spread to other sites, we see, however, a significant drop in 5-year survival to less than 20%, which again highlights the importance of early and regular screening. Next slide. So when it comes to screening, tests are usually divided into 2 main groups. Your stool-based, which includes the fecal occult blood test, FIT test, and Cologuard, and visual test, including colonoscopy, flexible sigmoidoscopy, and CT colonography. Next slide. Stool-based screening is utilized to detect colorectal cancer by testing for the presence of occult blood or cancer cell DNA that's shed into the stool. And in general, the advantages of these tests are that they're non-invasive, can be done in the privacy of your own home, and they don't require the not so lovely bowel prep. However, the disadvantages are the fact that, they have to be repeated anywhere from annually to every 3 years, may not detect the presence of smaller precancerous polyps. And, if any of these, tests are positive, then they require a colonoscopy anyway. Next. In terms of visual-based testing, the gold standard remains colonoscopy, as it can both detect and remove precancerous polyps and diagnose cancers that have already developed. The disadvantages, of course, are the fact that it's an invasive procedure, not without risk, requires anesthesia as well as a bowel prep. Your other visual tests include a flexible sigmoidoscopy, which, unlike colonoscopy, doesn't require sedation or full bowel prep, but only allows you to examine the left side of the colon, potentially resulting in other polyps or cancers being missed. And finally, although it's not utilized very much, there's CT colonography or virtual colonoscopy, which is essentially a special CAT scan that allows you to view the lining of the bowel in greater detail. But similar to stool-based testing, if polyps or cancers are found, then it still requires subsequent colonoscopy. Next slide. So if a person's diagnosed with colorectal cancer, the next thing we do is something called a staging workup. Basically, we need to know if the cancer is still localized or confined to where it started, or if it's spread to lymph nodes or other sites, as this influences our treatment recommendations. The staging workup for both colon and rectal cancer includes a CT scan of the chest, abdomen, and pelvis. And for rectal cancers, typically a pelvic MRI, or if there's a contraindication to receiving one, a special rectal ultrasound is utilized to get more detail about the rectum and the pelvis. Next slide. We also routinely test the cancer for the presence of those gene mutations found in patients with Lynch syndrome, since again, this can impact treatment, and also get a baseline CEA level, which is a blood tumor marker that can be elevated in patients with colorectal cancer. Now, while an abnormal CEA can certainly aid in making a diagnosis of colorectal cancer, it alone is not diagnostic and can't actually be used as a screening test alone. There are some patients with colorectal cancer in which their CEA is normal, and there are some conditions in which the CEA level is actually elevated, even though those conditions are benign. So what it's most useful for is in the surveillance period, or once you've completed treatment, where it can serve as an early indicator of recurrence. Finally, depending on the complexity, at times we discuss, cases in what's known as a tumor board meeting, which is essentially where, surgical, medical, and radiation oncologists, pathologists, radiologists, et cetera, come together to discuss certain cases and come up with individualized treatment plans. And these meetings are really beneficial because studies have shown that these meetings help to improve coordination between providers, ensure adherence to nationally recognized treatment guidelines, and helps to increase clinical trial enrollment, since without trials we can't continue to make strides in cancer care. Next slide. So basically, we take all the information we gather from the workup and come up with a stage. And as with a number of other malignancies, colorectal cancers are staged using the TNM staging system, with the T, or tumor, indicating the depth of tumor spread throughout the layers of the bowel wall, N representing the presence or absence of surrounding lymph node involvement, and M indicating the presence or absence of cancer spread to distant sites. Next slide. And so ultimately, we put those three things together to come up with the stage. And again, as previously mentioned, the stage at which you're diagnosed influences survival, and as well as your treatment recommendations. Next slide. So for non-metastatic colorectal cancer, based on your staging workup, treatment may include a combination of surgery, systemic therapy, so that includes chemotherapy or immunotherapy, and radiation. Next slide. And starting with surgery, cancers in the colon can be treated with endoscopic resection or colectomy. Next slide. Endoscopic removal basically entails removing a cancerous polyp at the time of colonoscopy. And this is reserved for cancers that are very early stage and involve only that first layer of the bowel wall. This also includes cancers in which there's no suspected lymph node involvement, and with what we consider to be low-risk features microscopically. These are typically polyps that are on a nice little stalk, like we see here in this picture, that can be removed in one piece with clean edges. And for these patients, once the cancerous polyp is removed, typically no additional treatment is needed, with the exception of a colonoscopy to evaluate that area 6 to 12 months later. Next slide. Unfortunately, most cancers are too advanced for endoscopic removal, warranting a larger surgical resection called a colectomy. This is a diagram of the colon, which, as I tell my patients, is shaped like a big question mark. And as you see here, it gets direct blood supply from the aorta, so the largest vessel in our body, and kind of peppered along these branches from the aorta are the lymph nodes. Next slide. The goal of a colectomy is to remove the involved portion of colon along with its associated lymph nodes with clean margins or edges to ensure that when we go to put the two ends back together, we're not leaving cancer behind. Occasionally, the entire colon may need to be removed, which may or may not require an ostomy bag, but this is not the case for most patients. Next slide. In terms of rectal cancer, surgery ranges from endoscopic removal to transanal resections to then larger transabdominal procedures, which include low anterior and abdominal peritoneal resections. Next slide. As the name implies, transanal resections are approached from the anus and entail removing a full thickness area of rectum containing the cancer with clear edges. With this approach, the lymph nodes are not removed, however, making it appropriate only for small early stage cancers with low risk features and no pre-treatment concerns for lymph node involvement. Next slide. The advantages of transanal resections are the fact that they're less morbid of a procedure, they're sphincter sparing, and typically, these surgeries are done on an outpatient basis. But the disadvantages are the fact that they lack that complete staging with the lymph nodes, and they have slightly higher rates of local recurrence compared to the transabdominal resections. Next slide. However, if you're dealing with a more advanced cancer, especially in ones where the lymph nodes may be involved, a transabdominal operation is necessary, for which the type of surgery chosen is highly dependent on the exact location of the cancer. The rectum, as we see here, is divided into 3 sections: low, middle, and upper, based on the location, from the anus. And as you see, they're wrapped along the lower part of the rectum is this broad band of muscle that helps to make up the sphincter, which is what helps us to maintain continence. From a lateral or side view, you can appreciate the close proximity of the rectum to the uterus and vagina in females, as well as the bladder and prostate in men, making this area sometimes a challenging region to operate in. Next slide. So for most upper and middle third rectal cancers, we can remove the portion of rectum containing the cancer while preserving the sphincter. This is known as a low anterior resection, or LAR. We can also accomplish this with some select lower third cancers as long as we can achieve those clear margins or edges without cutting through the sphincter. And depending on the location and if the patient received chemo and radiation therapy up front, this may require an ostomy, although in the majority of cases, this is temporary. Another disadvantage is the fact that although patients can be reconnected typically, because they end up losing the majority of their rectum, their bowel function may be altered, which for some patients can have some impact on their quality of life. Next slide. For the majority of cancers in the lower third of the rectum, however, and especially those that involve the sphincter muscle, a complete removal of the rectum with sphincter muscle is advised in order to ensure complete removal of the cancer with clear margins. With the sphincter muscle gone, this necessitates the need for a permanent colostomy, which of course no one desires. But with that being said, as I tell my patients, well, it takes some time to get accustomed to. Folks with permanent colostomies or ileostomies are able to live, very full lives. Next slide. Both of these procedures, and as well as some colectomies, can be accomplished via the more traditional open route versus, with a minimally invasive approach with the laparoscope or the robot. Next slide. And the advantages of a minimally invasive approach includes smaller incisions, which ultimately means less intraoperative blood loss, less pain, lower risk of infection, as well as a faster return of bowel function and therefore shorter stay in the hospital. We're also able to see better, especially down in the pelvis, with a laparoscopic or robotic approach, which is always very helpful for us surgeons. Next slide. Through a number of trials, we also know that the oncologic outcomes are the same between an open versus a minimally invasive approach. In general, the rates of recurrence, survival, and the ability to achieve clear margins are the same, which basically means we can do just as good of a surgery without sacrificing cancer-specific outcomes. Next slide. So moving on, we can use targeted radiation beams to cause direct damage to the cancer cells. This can be employed either before or after surgery, mainly in the setting of rectal cancer. And preoperatively, radiation can help to shrink the cancer to make surgery potentially less extensive, make sphincter preservation possible in some patients, and reduce the risk of future recurrence. Postoperatively, it's used to destroy any microscopic cancer cells left behind and can be used to palliate symptoms both in the metastatic and non-metastatic setting. Next slide. In terms of systemic therapy, this includes your more traditional chemotherapies, which are drugs that are used to directly kill cancer cells, along with immunotherapy, which is a group of drugs that stimulate the immune system to identify and fight cancer itself. And like radiation, this can be used either in the pre or postoperative setting and is a major component of treatment for metastatic disease. Next slide. As previously mentioned, metastatic disease is where patients have spread of their cancer to distant sites. For colorectal cancer, the most common sites of spread include the liver, lungs, abdominal wall lining, or the peritoneum, distant lymph nodes, and bone. And as we see here, this is a CAT scan image of a patient with metastatic lesions throughout their liver. Next slide. With regards to treatment of metastatic disease, this is approached with either a curative or palliative intent, depending on the extent of disease, location of the metastatic lesions, the patient's condition, as well as their treatment goals. As previously mentioned, systemic therapy is the most commonly used modality in this setting, but if feasible, sometimes we can surgically remove metastatic lesions. Radiation is commonly employed for disease control and palliation, along with what we call ablative therapies like radiofrequency ablation or RFA and embolization. With RFA, radiofrequency waves are used to essentially generate heat to destroy diseased tissue through placement of a special probe directly into the tumor. And with embolization, radioactive particles are injected into the tumor with the catheter. Chemotherapy can be delivered directly to the tumor while cutting off the main vessels that feed it. Finally, for those in which other therapies aren't an option because of either disease progression or patient's overall health, the focus is placed on what we call best supportive care with symptom management and possible hospice enrollment. But all in all, what this slide should convey is that even in the setting of metastatic or stage 4 disease, that there are many treatment options available with the ultimate goal of prolonging time without compromising quality of life. Next slide. Once patients have completed treatment, we follow them very close for a minimum of 5 years to ensure that if there is a recurrence, that we identify and treat it early. 80% of recurrences occur in the first 3 years after surgical resection, and 95% occur within the first 5. And depending on the stage, surveillance entails regular scans, labs including that CA level, and for those who have undergone a resection, typically they are recommended to undergo a repeat colonoscopy 1 year after surgery. Next slide. Finally, I'm sure most of you are wondering about how you can reduce your risk of developing colorectal cancer. And, while the rise we're seeing in young patients is still somewhat of a mystery, although I certainly have my ideas, you can, in general, minimize your risk by engaging in regular screenings when eligible, eating a healthy diet low in processed food and red meat, remaining physically active, limiting alcohol consumption, quitting smoking, and of course, reporting any suspicious symptoms to your healthcare provider. Next slide. That's it. Hopefully that was a comprehensive enough review.